Hello, and welcome to our scientific update on the COVID-19 pandemic. I'm Roy Parker, the director of the BioFrontiers Institute and a professor of biochemistry at CU Boulder, and I'm joined by Kristen Bjorkman, who's our Institute Director of Interdisciplinary Research. What we're going to do today is try to talk about what we're learning about the COVID-19 pandemic and how that influences the policies at CU Boulder for this semester and semesters going into the future. I want to emphasize that this is our best interpretation of the current data, and that as we've all become familiar with, the pandemic is changing over time as we learn more about our immunity induced by the vaccines, and also as the COVID-19 virus evolves and creates new variants that have new properties. Now, one of the main points I want to make is that this is the new normal. The COVID pandemic is not going to go away, it's here to stay. And what we should expect is really two broad trends. One trend is that the immunity of individuals will increase over time, both from vaccination and from prior infection. And people who have immunity to these viruses will get less severe disease. And that's a really terrific thing. However, over time, we should expect new variants of the virus to emerge. And some of those viruses will have increased transmissibility, like the Delta variant we'll talk about today. And some may have the ability to partially escape our immune responses. That will lead to waves of new infections, correspondingly increase immunity in the population, and then that wave of infections dying down. Now, one of the reasons we think this is the new normal is that we don't see any new technologies that are really going to impact COVID in the short term. And this is really because the scientific community has made tremendous strides over the last year and a half to put in place tools for us to combat the COVID pandemic. We now have terrific vaccines, which are protective against infection and highly effective in protecting from severe disease. We have a robust testing network, including simple tests that you can do at home for $10. And we have some antivirals, such as the monoclonal antibody therapy, which is effective when given early. If we look out in the future, we can imagine that in the next year or so, there'll be some incremental changes in these areas, but it really is going to be years before there's significant and really meaningful changes. And so because of that, what we have to understand is that, we're now no longer operating in an emergency setting. This is really the new normal of what we're going to be in for the next several years. And our response to that, therefore, has to be a type of sustainable management. Now, our best tool for against COVID is really vaccination. And if you look across the country, the state, and Boulder County, we now have between 60 and 76% of people who are eligible fully vaccinated against COVID. Estimates of prior infection are that about 44% of the people in the US have already had COVID, a little bit lower in Boulder and County and Colorado. And that leads to potential total immunity of the people over 12 years old, somewhere between 78 and 89%. Now at CU Boulder, we've implemented a vaccine mandate that all students and employees have to be vaccinated or opt out for a specific reason. The due date, which has to be completed by, is September 15th, and this is our current status. About 79% of our employees and 73% of our students have fulfilled the process. And the university has verified that 96% of those reporting are actually vaccinated. And that's really terrific. That means that we're going to be a highly vaccinated community at CU Boulder this year. The people who have not reported does not mean that they are not unvaccinated. They just haven't completed the paperwork, or the university hasn't completed the verification process. So we're going to be a highly vaccinated community, and that's going to be really important in how we're going to manage COVID over the next year. Now, one of the key things for going forward is to understand the current state of the pandemic and the Delta variant. And to do this, to discuss this, I want to turn it over to Kristen, who's been digging into the data in this area.
Thank you, Roy. So let's talk about how all of this intersects with Delta. Next slide, please. So what do we know about this Delta variant? So I think we're all pretty aware that our pandemic currently in the United States is being driven by the Delta variant. And this is illustrated really strikingly in that graph on the right from the CDC, where we're looking at a slice of time from mid-May through mid-August. And you can see that in mid-May, Delta represented only about 4% of cases in the country. But by mid-August, it was 99% of cases. So this rapidly took over from the Alpha variant, which was dominating in the spring. And why did this happen? So a lot of data now is supporting the conclusion that the Delta variant is more infectious. And one way that this is measured is by looking at this value known as R, which represents the average number of people infected by someone who is themselves infected. So that R value is greater than the R that was associated with Alpha, which was itself greater than the R associated with the original ancestral strain. But another thing to keep in mind is that this number can vary. So the actual value of R depends on factors like population susceptibility. So how many are vaccinated, how many may have immunity from a prior infection, and public health protocols. What types of measures are people taking in terms of masking, distancing, those types of things. So why is the Delta variant more infectious? So we're still learning more about this, but one thing is that this may be partially due to higher viral load. So when you hear that, that is indicating that people who are infected with this variant are producing more virus and therefore shedding more into the environment, which may put their contacts at higher risk of becoming infected. Next, please. Importantly, though, the vaccines are still limiting infections that are caused by Delta. So let's consider two parameters: vaccine efficacy against becoming infected in the first place, and vaccine efficacy against severe disease. So if we consider effectiveness against infection, so basically just testing positive, the estimates for Delta range from 66% in high exposure risk populations, like healthcare workers, to 80% in general population. And that's illustrated to you by an example from New York State in that graph on the left, where it's showing you, again, a period from May through the end of July. And it's looking at an Alpha dominant period, which was May, and you see about 92% protection against infection for vaccinated individuals, versus late July, which was a Delta dominant period, where that has dropped to 80%, which is still a high value, but does represent a decline. But let's consider protection against severe disease, because really that's something that we want to avoid as much as possible. That has remained very high at 95% in multiple studies, including this one from New York, which is shown in the graph on the right, where if we look at protection from hospitalization, that's remained really solid at about 95%, whether it was Alpha or Delta dominating the cases. And another thing I want to point out is that in this time period, both the case count, so people testing positive regardless of symptoms, and the hospitalization, so severe cases, those rose faster for unvaccinated individuals than they did for vaccinated people. Next, please. So what about breakthrough infections? Why do we have this gap between protection from infection and protection from severe disease? These breakthrough infections in a vaccinated individual do happen, but importantly, they are rarely severe. So if we look first on the right, we see an example from Oregon, and this is holding true in multiple studies. But what we're seeing here is the period from January 2021 through July, so vaccine being rolled out and then being widely available. And in gray, you can see the case rate. And this is people who are testing positive, whether they have symptoms or not. And you can see that there are two noticeable jumps here. One in the spring when Alpha came to dominate in the state. And as we mentioned, that was more infectious than the ancestral strain. And then again, later in the summer, a noticeable jump when Delta became dominant in the state. However, if you look down at the bottom of that graph, the blue line, that represents the people who are being hospitalized, who are vaccinated. and that's remained consistently low. And in fact, even during that Delta dominant period, there's a 17-fold difference between the case rate, so testing positive for any reason, and the people who are actually in the hospital, indicating really good protection despite a rise in asymptomatic or mild cases in those breakthroughs. So now if we consider the country as a whole and severe disease, we have now almost 174 million fully vaccinated Americans, but we've only logged about 11,000 severe breakthrough cases. So meaning they're either hospitalized or fatal. And that represents just 0.006 of the total vaccinated population. And if we consider who these individuals are who are suffering these severe consequences, 73% are actually over the age of 65. And we know that's a higher risk group, whether they're vaccinated or not. But furthermore, 25% of these severe cases actually were not hospitalized for COVID-related reasons. So they may have been there because they had cancer, and then because it's routine practice to test, they found that they also had COVID, but that was not what drove them into the hospital. And it's a similar statistic for fatal cases. 21% were not actually due to COVID. So this is encouraging. Next, please. But why are we seeing more breakthrough cases? So the first reason is unvaccinated people are driving infections in undervaccinated communities. So we see this regionally across the US, for instance, where the areas that have very low vaccination rates are having higher caseloads in the unvaccinated, and also then driving that in vaccinated people. We're also seeing that Delta breakthroughs are more common than non-Delta. So breakthroughs due to Alpha, for instance, happen at a lower frequency than breakthroughs due to Delta. Also, for certain higher risk populations, such as immunocompromised individuals, there does seem to be some waning of protection. So the time since vaccination means that they are then at a higher risk of a breakthrough case. And this is driving recommendations for a third dose for that group who may not have achieved good enough protection from the 2 doses. But finally, and this is maybe not completely intuitive, but very important, if you have a highly vaccinated population, the more people who are vaccinated means the more total breakthrough cases you're going to see. So let's imagine a scenario that represents, as Roy showed us, CU quite well. Let's imagine you have a 95% vaccination rate with a vaccine that's 80% effective against infection, so test positive for any reason. We actually expect that of all the cases detected, 80% of them will be in the vaccinated. But importantly, those are not expected to be severe, and the total case count is reduced by having a highly vaccinated population. Next, please. So what about transmissibility? I know people are concerned, that they've done their due diligence, they're vaccinated, they thought they could protect others around them as well as themselves, and now we're hearing some reports that breakthroughs can be transmissible. So yes, there are instances of that, and that can happen, but it's not as likely as transmission from an unvaccinated case. So one key point is that unlike unvaccinated infections, infectious breakthroughs seem to be mostly in symptomatic people. The reason we care about that is it's easier to identify that you are infected. So you have more awareness because you have symptoms. You could quarantine, you could test. So that's helpful in preventing transmission. Another thing that limits potential transmission from a breakthrough is we are seeing multiple pieces of evidence that the infectious period for somebody who has a symptomatic breakthrough is shorter than an unvaccinated case. So their viral levels are dropping faster as the immune system clears that out, which is great. And then another thing is that we have been hearing reports that breakthroughs can have as much virus as an unvaccinated case with Delta. And really, the basis for that is PCR test results, which gets used as a proxy for viral load because it's looking at the presence of the viral genome. However, while we really understand that correlation very well in unvaccinated individuals, That's not quite as straightforward for vaccinated individuals. And in fact, we find that the virus amount that they are shedding is lower. And that's illustrated too in this cartoon on the right, where we have an unvaccinated case who's producing a certain amount of virus and they test positive by PCR at a certain level. And then we have a vaccinated individual who is producing actually less infectious virus, but a lot of essentially fragments of virus that contain the viral genome. So they would test positive at the same level, but actually have less infectious virus on board. So these breakthroughs appear to have as much virus, but the actual amount that they're shedding is often lower than an unvaccinated case. Next, please. So if we summarize these breakthrough data, the trigger for many of these cases is exposure to an unvaccinated case. Then the outcome in a vaccinated person, most of them, the virus levels never reach detection. So we do see, good protection from infection in the first place. Some individuals will sustain an asymptomatic infection, but importantly, there's little documentation of viral shedding from those people. So they are, low risk, hopefully, to others. A few people will have a mild case, so they'll experience some symptoms, not enough to send them to the hospital. They may shed virus, but it's less common than an unvaccinated person. And then in rare cases, there are breakthroughs that will cause severe disease. They tend to be in higher risk groups. They do likely shed virus. So the bottom line, some breakthrough infections can infect others, mostly unvaccinated people would be highest risk. But breakthrough infections are expected to be less infectious than an unvaccinated case. And I'm going to turn it back to Roy to talk about what we think this means for CU.
Thank you, Kristen. So I want to go back and look at what are the goals at CU this semester and going forward. And I think the predominant goal of the university is to keep our communities safe from severe disease in a sustainable manner. And that's coupled with trying to provide as optimal an educational experience as safely as possible. And then finally, I think it's important for the campus to provide analysis of the current science to try to inform the campus about what's going on with the pandemic and how that influences university policy. Now, our best tool against COVID is really vaccination. And this is really because vaccination not only prevents infection, between 66 and 80% effective against the very infectious Delta variant. So that's actually a quite good vaccine. But in addition, vaccine is even better at preventing severe disease. And that's really terrific because it's one thing to get sick and be at home for a few days. It's another thing to end up in the hospital. Vaccination also has an effect on spread from people who have breakthrough infections, as Kristen just mentioned. It's been very difficult for the scientific community to understand how big this effect is. We think there is some effect because vaccinated people shed less viable virus than unvaccinated, and they clear the virus faster from their system. But whether that's a big effect or a small effect really requires further study. An important aspect of vaccination is that if we have 95% vaccination in our community, R naught, or the number of people infected in an average case, will be less than 1. And that's terrific because that's what you need to prevent COVID outbreaks. Now, another tool we have to combat COVID is masks. Masks are pretty good at preventing infection, and depending upon the quality of the mask and how well it's worn, different studies suggest masks can be 20 to 80% effective at preventing infection, and similarly effective at preventing continued spread from people who are infected with COVID but don't know it. One thing about masks is that they cannot prevent severe disease. So once you're infected, masks do nothing for the outcome of your potential disease case, but masks are a good tool that we can use, and they're relatively easy and inexpensive to implement. Now, the university is often asked, why did the university discontinue monitoring testing for SARS-CoV-2 that we did last year? And there's really two main reasons. And the first is, as I just mentioned, in a very highly vaccinated community, and we estimate CU Boulder is going to be around 95%, the spread of COVID is estimated to be less than 1, and therefore we should not have COVID outbreaks on campus. So that's really important, and that's really the power and the usefulness of these vaccines. The second reason that the university discontinued monitoring is that monitoring testing in practice has a relatively limited impact on continued spread. And I want to point out that monitoring does not affect the initial infection. We detect people after they are infected, and monitoring works when you test 100% of your population who are asymptomatic, because those are the people you're trying to find cases that you don't know about. And if you do that, testing people once a week, you get about a 50% reduction in the spread of COVID disease if 100% of people in your community participate in that effort. Now, last year we had really terrific participation in the dorms, which we required testing during the fall semester. That included lots of enforcement and encouragement to get tested. During the spring last year, we mandated a campus-wide testing strategy. And the reality was we had very declining participation. Participation declined even further over the summer. And so because of this low level of participation, implementation of a monitoring testing is really going to have a small effect on spread on campus, particularly when we're so highly vaccinated. And so that's why the second reason that we have not continued monitoring testing. The universities also asked frequently, why not just test the unvaccinated individuals twice a week? This is a process that several other universities and organizations are implementing. However, our mathematical analysis of this suggests that, if we just test the unvaccinated communities, in our community, which is 95% vaccinated, it will have a very small effect on overall transmission. And in fact, we estimate less than 10%. And that's really pretty simple to understand. The majority of people are vaccinated. And as Kristen pointed out, because of that, the majority of cases are going to be in the vaccinated individuals. And even though they don't spread as well as unvaccinated people, they can still have a contribution to spreading on campus. So there's not much value in testing the unvaccinated individuals twice per week. So what do we expect to happen at CU this semester? So we can think about cases at CU as really being the outcome of a mixture of two groups. We have a small unvaccinated community, and an unvaccinated community by themselves with a very infectious virus, such as the Delta variant, would have an R0 of around 6, and that would lead to a very rapid spread of disease. We'd see outbreaks of cases, and then as pretty much everybody gets infected, the group will reach herd immunity, and cases will drop rapidly. Now, the majority of our community is vaccinated, and a vaccinated community by itself has a very low R0, somewhere between 0.3 and 0.7. So you'll see some breakthrough cases, but with very limited spread. And those breakthrough cases would come from exposure to outside groups. Now, when we mix these two groups, as we have a CU Boulder campus, there's two main consequences. One consequence is that the infection rate of unvaccinated individuals is declined. And that's because they're no longer always running into other unvaccinated individuals. They're now running into vaccinated individuals who have a lower probability of being infected or transmitting disease as well. So that flattens the curve, and this is the kind of thing that we've heard about over the last year and a half as we've tried to preserve our healthcare system. The other consequence that occurs is because our vaccinated individuals are interacting with an unvaccinated group who has a higher chance of being infected, that will lead to more breakthrough cases in our vaccinated individual, and those are generally proportional to the cases in the unvaccinated community. So if we take those two things together, what we think will happen at CU this semester is we're going to get an increase in cases. The majority of those cases are going to be breakthrough cases on campus, and that's because 95% of our individuals here are vaccinated. Those case numbers will plateau and then persist and then eventually decline as COVID becomes really an endemic disease. The height of that plateau really depends on how effectively vaccines limit transmission from vaccinated individuals that have breakthrough cases, and that's something we don't know a good number for yet, but we know there is some effect there. The vast majority of breakthrough cases will have mild symptoms. That's not to say people won't feel sick, but we do not anticipate a lot of hospitalizations arising because of breakthrough cases. And then finally, I just want to emphasize that we anticipate, based on our mathematical modeling, that unvaccinated individuals have a high probability of being infected this year, even in a 95% vaccinated community. So if you're unvaccinated and you're thinking, I'm going to be protected because so many people around me are vaccinated, I would like to dispel that notion, and I would urge you to get vaccinated to protect yourself and to contribute to community health measures. What else can CU do to maintain a safe environment during COVID? We've recommended that we push to increase vaccination rate as much as possible. For example, CU could work with bars and restaurants in the community to require vaccinations for entry to encourage more individuals to get vaccinated. We provide diagnostic testing using an FDA-approved test at the Wardenberg Student Health Center, and that's going to be continuing on campus. If it's feasible with the supply chain, the university is looking into trying to provide free take-home antigen tests for COVID, 2 per week, to requesting CU students, staff, and faculty, so that individuals who want to test themselves at home can do so. The university is watching test demand and percent positive at Wardenberg, as well as the county, to see if we have any potential outbreaks, which we have not seen so far. And then right now, the university is requiring masks indoors while this case plateau persists. A reasonable recommendation is to lift that requirement when vaccination reaches 90 to 95% of the community as a verified level, and the county cases decrease to at or below moderate transmission as defined by the CDC. Now I want to turn this over to Kristen to talk about 2 groups of concern that we pay a lot of attention to.
Thanks, Roy. So one of the major groups of concern, of course, is children under 12, which we know are in the households of many of our CU affiliates. The reason they are of concern is because they are ineligible for vaccination, and so that can make them susceptible to infection. The other group that we think about are older and immunocompromised adults. So they're at higher risk of severe disease to begin with, and they may need a 3rd dose based on what we're seeing in the literature. So they may not have quite as high protection from the vaccine as somebody who's younger and healthier. Importantly, data from schools and long-term care facilities indicate that one great thing that we can do to protect these groups is surround them by vaccinated adults. So even though risk is never zero, and we talked about potential transmission from a vaccinated adult, it's still going to be a much safer environment if we can surround these people, do our part to protect them with being vaccinated ourselves. So let's look at data a little more closely relating to children. So if we go to the next slide. We're hearing a lot of statistics about increases in child cases. So why is that happening? So for a good portion of these cases in children, their exposure was an unvaccinated adult who was infected and transmitted to them. So we see this in community patterns where undervaccinated communities have higher child rates. And we see these in case studies where unvaccinated adults have ended up infecting children. Importantly, we also, with school resuming, have increased testing in this population. So again, we're talking about case counts. So people who may be asymptomatic or mildly symptomatic, they may not have been tested heavily before school started. And then that's part of a lot of school safety operations, is to test these populations. So we may be discovering cases they actually didn't know about before, but could have existed. And as a lot of comparisons are being made to last year, if you recall, the test penetrance for these age groups was actually quite low. But let's consider the next question. Are these cases generally more severe? We are hearing about more total children in the hospital. However, the proportion of current cases that are happening in children is still quite low. They represent a small fraction of total cases. So really, we need to gather more data to see what the individual risk of severe disease might be. But we are still seeing that as a whole, the child fraction of disease cases is lower. So what about the school environment? So there's a couple of studies that can help us understand schools. And one involved over 100,000 school children in North Carolina last year, which was pre-Delta, but it also was pre-vaccine. So there were no vaccines available last fall. And they were implementing precautions such as masks and distancing. And importantly, they saw virtually no transmission in school. And those that they did see were linked to unmasked exposures. This really points that we have a way to keep school safe for children. And another important study was in England this summer. So they have a summer term, and this was a Delta prevalent period. However, they have very high vaccination rates among school staff, at least 90% with partial vaccination or full vaccination. And children under 18 are actually not eligible for vaccination. So we do have a mixed population of primarily unvaccinated children and a highly vaccinated staff in a Delta prevalent period. And what they saw was very low incidence in students and staff. And furthermore, if we consider the rates of child infections in the surrounding community, those were higher than the rates in school, still pointing that school can be a safe environment and our kids can be in person. So I'm going to turn it back to Roy now.
Yeah, so I just want to emphasize that, as Kristen said, surrounding children and vaccinated adults with vaccinated adults really can help keep case rates low, and we can layer on top of that the additional precautions of masks. Okay, so I just want to close by mentioning kind of what we think the key points are. One is that COVID-19 is now endemic and requires a sustainable response. Vaccination is really our best tool to manage both disease severity and also the spread of more disease. We should all expect that breakthrough infections will continue, but the risk of severe disease to vaccinated individuals is really greatly reduced. And then, Boulder County and CU are both highly vaccinated communities, but increasing vaccination rates higher will have additional public health benefits. I'd like to thank you all for joining us, and hope we've answered any questions you might have. Thank you.